Welcome all. So we begin with today's session. So today we will start with carcinoma of vulva. We will take this into two sessions. The first session, we will mainly focus on the definition, epidemiology, surgical anatomy for this vulva, then etiology and risk factors for the development of the carcinoma, pathogenesis, premalignant lesions, clinical features, how does the malignancy spread, what are the investigations and latest FIGO staging. And please listen this FIGO staging very well, understand the concept, okay? Because your viva can also go on the FIGO staging, okay? So carcinoma of vulva is actually a malignant tumor arising from the vulval epithelium. Most commonly, it is a squamous cell carcinoma involving the labia majora, labia minora, clitoris, vestibule, or the perineum. Okay, so it's a malignant tumor arising from the vulvar epithelium, and histopathologically, it is a squamous cell carcinoma most of the times. Okay, so there are certain important facts about this vulval malignancy. It represents 4% of all gynecological malignancy. Majority are diagnosed early in stage 1 or 2. Advanced disease is more common in elderly patients above 70 years of age due to the delayed diagnosis. Biopsy of any suspicious lesion is mandatory. So that is why when you get any lesion on the vulva, you have to do the biopsy. Okay. So from examination point of view, any persistent vulval region should be biopsied. Never treat a suspicious lesion empirically without histological confirmation. Okay. So if you have any suspicious lesion on the vulva, you should take the biopsy. That is what is the most important thing which you should do. Then what about the global burden of this vulval malignancy? This is not a very common gynecological malignancy. So common gynecological malignancy represents around 4% of female genital tract cancers. Majority are squamous cell carcinomas, usually affects the postmenopausal women. And age group you should concentrate, because you see this in two different age group population, and their nature is also, the histopathology is also different. Okay, so the one which has beginning is quite early or seen in relatively young age, but diagnosed below 55 years of age, that is associated with HPV. Okay, so when you get this vulval malignancy in postmenopausal women, but less than 55 years, generally it is associated with the HPV associated malignancy. This is okay, and those patients in whom this malignancy is seen after 70 years of age, generally this is a HPV independent tumor. So here the pathogenesis is different, not the HPV, and often it is associated with the Lichen sclerosis. Okay, there is a separate session, there is a separate video on this benign vulval lesions. Please listen to that video also. Okay, so different age group and different pathogenesis you have understood. Generally this around 55 years of age, what you get is a HPV associated tumor, and the one which you get after 70 years is HPV independent tumor, and most of the time it is associated with lichen sclerosis. Okay, so surgical anatomy of the vulva. What are the components of the vulva that you should describe? The vulva will include the mons pubis, the labia majora, labia minora, clitoris, vestibule, vestibular bulbs, Bartholin's glands, parauretral glands, urethral opening, and vaginal opening. We should know this particular thing because the malignancy will spread accordingly, nearby structure. One important landmark you should know is a heart line. Okay, so this can be asked in the vivas also, the heart line. So what exactly this heart line is? The heart line is the junction between the keratinized squamous epithelium, which is situated laterally, with the non-keratinized squamous mucosa, which is medial. Okay, so this vulva has got the squamous epithelium, but the lateral epithelium is a keratinized, while the medial it is non-keratinized squamous mucosa. Okay, the lymphatic drainage is the most important, and you may be asked about the short note on the lymphatic drainage, or there can be question. It's a part of the full question also. So if you see this vulva, you will find that the lymph node which are draining this area, the vulva, is the superficial inguinal lymph nodes. Then you have deep inguinal lymph nodes and the iliac lymph nodes. Okay, so it goes to the superficial inguinal, then it goes to the deep inguinal, and in the deep inguinal, the most important is the lymph node of Cloquet. Okay, also called as Rosenmuller's lymph node. Okay, and then it goes to the iliac node, and one of the peculiarity is the medial, the midline 2 centimeter, the area which is there 2 centimeter in the middle, 2 centimeter are lateral to this particular midline. So that drains bilaterally. So when you are doing the lymph node dissection, and if your lesion is in the midline, then you have to assess both the sides lymph nodes, groin dissection you have to do. Okay. But if the lesion is lateral, okay, and if you need the lymph node assessment, then in that particular case, unilateral lymph node assessment or the lymphadenectomy is sufficient. Okay, so the primary drainage for this is a very important concept. Okay, so the primary drainage of the lymph node is a superficial inguinal lymph nodes. Then it goes to the deep inguinal lymph nodes. In the deep inguinal lymph nodes, the most important is the lymph node of Cloquet. Then it goes to the iliac group of lymph nodes, and then the pelvic group of lymph nodes. Another important thing is a midline lesion. Lesion within 2 centimeter of the midline will drain bilaterally. So you require a bilateral groin assessment when you have a midline lesion. This concept you have to understand well. If your lesion is situated laterally, that means lesion is more than 2 centimeter lateral to the midline, then usually they drain ipsilaterally. So ipsilateral lymph groin dissection is sufficient. Okay. Then coming to the etiology and risk factors, we have seen two different etiology. One was HPV associated and second was HPV independent, which is associated with the Lichen sclerosis, LS. Okay. So first pathway is a HPV associated carcinoma. This occurs in the younger women. Association with smoking is known, associated with HPV infection, and it is a multifocal lower genital tract neoplasia. Okay, so when you have such kind of lesion, you also have to do look for other lesions, maybe in the cervix, vagina also, because the HPV will cause the infection at other sites also. Okay, so and another histology which is very typical with this is a baseloid squamous cell carcinoma or Wartis squamous cell carcinoma. So the one which is associated with the HPV is a baseloid squamous cell carcinoma or Wartis squamous cell carcinoma. HPV is detected in around 50% of invasive cancers and more than 90% of VIN. Okay, so when you have a VIN in these patients, 90% you will get the HPV. Okay, another pathway for development of carcinoma of vulva is HPV independent carcinoma. This is associated with the Lichen sclerosis. It is seen in elderly women associated with Lichen sclerosis and frequently associated with P53 mutation. This is very important. So this LS associated or HPV independent is associated with P53 mutation, and histologically it is a squamous cell keratinizing squamous cell carcinoma. While here it was a baseloid and the Wartis squamous cell carcinoma when it was associated with the HPV. HPV independent is a keratinizing squamous cell carcinoma. Okay. Now, what are the risk factors? Increasing age. That is the strongest demographic factor. Then high risk HPV, that is the oncogenic infection. Smoking has got associated association. So it's a cofactor associated with the HPV. Then HSV infection is also additional cofactor. Then chronic immunosuppression, reduced immune surveillance. Lichen sclerosis, the one which is independent of HPV, will be associated with lichen sclerosis because that leads to the chronic inflammation. And VIN is a premalignant lesion. Okay, so these are the predisposing factors. So if you see the pathogenesis for HPV associated pathway is same like what happens with the CS cervix. It is the persistent HPV infection leading to the vulvar high-grade squamous intraepithelial lesion. What we call previously we used to call it is a VIN. Okay, now we label this as a HSIL. Okay, high grade squamous intraepithelial lesion. Okay, and further it will lead to microinvasion leading to invasive squamous cell carcinoma. This is HPV associated pathway. Second is a HPV independent pathway that is associated with Lichen sclerosis. It leads to the differentiated VIN. So the VIN which is associated with Lichen sclerosis is called as dVIN or differentiated VIN, and this is associated with P53 mutation. Okay, and typical histopathologically it is a keratinizing squamous cell carcinoma, while the one which was associated with the HPV was a Warty and the baseloid squamous cell carcinoma. Okay, so the current classification recognizes two biologically distinct pathways. One is a HPV associated, that is a vulvar HSIL, and second is a HPV independent, that is associated with dVIN or differentiated VIN. Okay, so the VIN initially the older terminology was VIN1, VIN2, VIN3, but nowadays we use LSIL and HSIL terminology. Okay. So similar to CIN, the VIN1 will correspond to the LSIL. Okay, that is the HPV effect. Okay, and VIN 2 and 3 we call now as a vulvar HCL, high grade squamous intraepithelial lesion. Okay, and when you have a differentiated VIN, we label this as a dVIN. Okay, so do not use these VIN 1, 2, 3 terminologies now, because these are older terminologies. Now they are replaced by the LCL and HCL, and similar to CIN, only VIN 1 or the mild dysplasia will correspond to the LCL, while VIN 2 and 3 will correspond to the HCL. Okay. Now coming to the clinical features. So most common symptoms is pruritus. So you may get a short note on pruritus vulvi. Okay, then evaluation will you have to mention everything. Okay, there may be visible vulvar lesion, pain, bleeding, ulceration, inguinal swelling. Okay, signs, there may be raised lesion, there may be ulcerative lesion or pigmentation, warty or multifocal. Okay, especially in the younger women, you may get a multifocal lesion. So from remembering point of view, we remember PUBI, pruritus, ulcer, bleeding, and inguinal lymph node enlargement. Okay, so these are very important from the vulval malignancy. How does this vulval carcinoma spreads? So spread of the disease mainly by the direct spread. So from vulva, it may spread to the urethra, vagina, perineum, anus, bladder, rectum. So nearby structures. Lymphatic spread, it will go to the superficial inguinal lymph nodes, deep inguinal lymph nodes, and then the pelvic lymph nodes will be involved. Then it goes to the third is a hematogenous, which is a late spread. Okay, it is a late feature, and common sites are lung, liver, and bone. So what investigation? First is a complete clinical examination you have to do. Apart from local vulval examination, you will also have to do per speculum examination and further routine investigations also. Okay. So complete vulval examination is required. You have to measure the tumor, that we will come to know during the staging. This measurement of the tumor size is very important. Second, you have to assess the groin lymph node clinically as well as on investigation. Okay. Then speculum examination, rectal examination if indicated. Okay. Vulvoscopy, 3% acetic acid application, because examination of the vulva may show acetobite areas, and then you will be able to take out the biopsy. Okay, that is vulvoscopy. Then histopathology, that is the gold standard, and you will be doing the punch biopsy or the incisional biopsy. However, if the lesion is small, then you may do the wide local excision also. Now what exactly this is there, that we will see later on. Okay, so punch biopsy or incisional biopsy of the lesion. So never treat a suspicious vulvar lesion without histological confirmation. Okay, so imaging, you have to do imaging, especially when the tumor is large, suspected nodal disease, and advanced disease. So you will do the imaging. The imaging technique is either CT scan, MRI, PET scan, or chest X-ray. Okay, this is to find out the involvement of the nodes. Okay, which nodes are involved, that also we have seen. The most important to understand here is a FIGO staging. Okay, so this FIGO staging, as usual, there are 4 stages. The first stage where the carcinoma is restricted to the vulva. Second stage where there is a local spread in the lower 1/3 of the perineal structures. Third stage is the most important stage you should understand. Third stage deals with the involvement of the lymph nodes, and fourth stage where upper 2/3 of the perineal structures are involved, or there is a distant spread. Okay, so this is just the overview to understand these particular 4 stages. First, when the carcinoma is restricted to the vulva. Second, when it spreads to the adjacent structures but restricted to the lower 1/3 of the perineal structures. Now, when we are talking about the lower 1/3, here lymph nodes are not involved. Once we say the lymph nodes are involved, that means we are talking about stage 3. Okay, and in stage 2, lower 1/3, we are talking about the perineal structures. But if it is involving upper 2/3 of the perineal structure, that means we are in the stage 4A. Okay, so lower 1/3 is not immediately followed by the upper 2/3. Lower 1/3 is stage 2. Then comes the lymph node involvement in the stage 3, and then comes the stage 4A where the upper 2/3 are involved. Okay, now this stage 3 where the lymph nodes are involved, there also you have to know three things you remember very well. One is the number of lymph nodes. Second, size of the lymph node. And third, extra capsular spread. Okay, Now we will go into the detail of this FIGO classification. Okay, so stage 1 is a tumor which is confined to the vulva, which is again divided into stage 1A and 1B. Okay, stage 1A and 1B. Now what does 1A mean? So lesion which is less than or equal to 2 centimeter in size, confined to the vulva or perineum, with the stromal invasion less than or equal to 1 millimeter, no nodal mets. Okay, here they have mentioned the lesion should be less than or equal to 2 centimeter in size. It is confined to the vulva or perineum, and the invasion is up to 1 millimeter. So up to 2 centimeter size of the lesion, restricted to the vulva, and depth of invasion or the stromal invasion is less than or equal to 1 millimeter. Again, here you remember, here equal to sign is in 1A, which is not with the carcinoma staging, where we have divided everything, where this equal to sign goes below in the next stage, while here in 1A the equal to sign is here. Okay, 1A. I hope you are getting this particular very minor important thing. Like we have divided their stage B1, B2, B3. Okay, less than 2 centimeter, 2 to 4 centimeter, more than 4 centimeter, where the equal to sign was in the next substage. Okay, so here stage 1A is up to 2 centimeter and depth of invasion up to 1 millimeter. 1B is lesion more than 2 centimeter in size, or 2 centimeter or more than 1 millimeter stromal invasion. If either is present, if the lesion is less than 2 centimeter but the depth of invasion is more than 1 millimeter, then it becomes 1B. To say that it is 1A, you have to have both lesion up to 2 centimeter and depth of invasion up to 1 millimeter, then only it is 1A. If either is not satisfying, then it goes to the 1B and there are no nodal mets. Okay, so no nodal involvement. Then stage 2, where tumor of any size with extension to the lower one third of the perineal structure, that is the lower one third of the urethra, lower one third of the vagina, anus, but nodes are negative. Okay, so stage 1, stage 2, no nodes. Now stage 3, where it is a nodal disease. Remember stage 3, where the nodes are involved. Okay, here size of the lesion is immaterial. Nodes involved, you go to the stage 3 minimum. Okay, so tumor of any size with or without extension to the adjacent structures, lower one third of the urethra, lower one third of the vagina, anus, etc., but with positive inguinofemoral lymph nodes. Okay, that is further divided into 3A, 3B, and 3C. Okay, so stage 3 is a nodal disease. I have already mentioned, when we are talking about the nodal disease, you have to take into account three things: number of the nodes involved, size of the node, and extracapsular spread. Okay, now if you get a extracapsular spread in the lymph node, then it is directly 3C. Okay, so you have a positive node of any sides, but if you get an extracapsular spread, you directly go to stage 3C. Okay, then if there is no extracapsular spread, then you look into the size and you look into the number of the lymph nodes. Okay, stage 3A, where stage 3A is again divided into 3A1 and 2. If you have got a single lymph node which is more than or equal to 5 millimeter, then it is stage 3A1. Okay, or with 1 to 2 lymph node mets which are less than 5 millimeter. So if you have got up to 2 lymph nodes but they are less than 5 millimeter, then still it is stage 3A. Okay, stage 3B, here two conditions are involved. Either you have 2 or more lymph nodes which are more than 5 millimeter in size, or second, you have 3 or more lymph nodes which are less than 5 millimeter. So when we are talking about the nodal disease, you have to look into size, number of the lymph nodes, and the extracapsular spread. If there is extracapsular spread, directly it goes to the stage 3C. If there is a only single lymph node, then it will be 3A. Then you see what is the size. If it is more than single, more than 5 millimeter, it is 3A. If there are two lymph nodes but less than 5 millimeter, then also it is 3A. Okay, if there are two lymph nodes or more lymph nodes, the size more than 5 millimeter, it is 3B. With 3 or more lymph nodes less than 5 millimeter, it will be 3B. Okay, so this is what is the classification of subclassification of the stage 3. Then go to the stage 4. Here tumor invades the other, that is the upper two-third of the urethra, upper two-third of the vagina, or the distant structures. Okay, so from stage 2, involvement of the lower one-third, upper two-third involvement is in the stage 4. Okay, or the distant structures. This is again divided into 4A and 4B. 4A, where tumor invades any of the following: upper urethral and vaginal mucosa, bladder mucosa, rectal mucosa, or fixed pelvic bone, or fixed or ulcerated inguinofemoral lymph nodes. So if the inguinal lymph nodes are fixed and ulcerated, then it is a 4A. Okay. If histopathologically you get extracapsular spread, it is 3C. But if they are fixed and ulcerated inguinofemoral lymph nodes, then it is a stage 4A. Okay, and even upper two-third involvement will also stage 4A, while stage 4B is any distant mates, including the pelvic lymph nodes. I hope this classification is very clear. It is not difficult. You just have to know logic what exactly. So this is just a simplification. Okay, this is not the proper classification, just a simplification. So stage 1, tumor confined to the vulva or perineum. Stage 2, where there is an extension to the adjacent perineal structures such as lower urethra, lower vagina node, but nodes are negative. Okay. Stage 3, where you get the inguinofemoral lymph node mets. This will be divided into one A, B, and C. Okay. Then you have stage 4A and 4B. 4A will be upper urethra, vagina, bladder, rectum, etc., or the fixed ulcerated groin nodes, and 4B is a distant mates, including the pelvic lymph nodes. Okay, so this is what is the classification. Okay, now coming to the important points to remember. So vulval carcinoma accounts for approximately 4% of gynecological cancers. Squamous cell carcinoma is the commonest histology. Pruritus is the commonest presenting symptom. Any persistent vulvar lesion will require a biopsy. Heart line is an important anatomical landmark. Midline lesion drain bilaterally. Lateral lesion usually drain ipsilaterally. HPV-associated and HPV-independent pathways both occur. We know, we have seen both the pathogenesis. Then Lichen sclerosis predisposes to HPV-independent carcinoma, and lymph node status is the most important prognostic factor. Okay, so that finishes the first part of the carcinoma vulva. Thank you.